These are the objectives of this presentation. We will look at the elements of the examination, the symptoms and signs of a patient. We will look at what is the meaning of constitutional symptoms and signs, and we will talk about differences between some terminology such as review of systems and systems review. We will also talk about the clinical skills of an actual hands-on examination. This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below. The clinical skills required to do a patient examination are essentially two. Number one is the ability to take a good history. And number two is the ability to perform a thorough physical examination requisite to the patient's needs. And that is very important. This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below. A comprehensive patient examination is called a history and a physical. As we learned from the clinical skills slide before, these are the two elements of a patient examination. So in short, it is called H&P, and a patient who presents with any complaint of any symptom will undergo a history and physical. Not all history and physicals have to be the same. They need to be detailed in some cases in which every organ system needs to be checked. And these cases include the ones that is a new patient. For example, you're establishing a new patient and a patient you expect to keep for life. In these cases, a detailed history and physical should be performed. Um, in case of sports physicals or work-related clearance for people to go back to work after injuries, the history and physical needs to be detailed. Same for military recruits, and definitely not explicitly stated here, but the another case that needs to be pretty um, detailed examination are the ones who are in the intensive care units. However, such a detailed history and physical is not routinely needed, especially for many physical therapy patients. Patients who present in physical therapy clinics, for example, come with specific complaints, a back pain, a shoulder pain, things like that. In those patients, it is okay to perform a cursory physical examination of non-related organ systems, but the one organ system that is most likely responsible for the symptom or the sign is the one that must be examined in great detail. So, for example, somebody presenting with uh, pain syndrome, shoulder pain, back pain, or similar, they need to be examined um, in a uh, in a detailed way for the local site, and most likely that would mean examining the musculoskeletal system, and you can focus right at the area of the problem with maybe some extensions above or below that area anatomically. However, it's not needed to delve into other organ systems unless there is compelling evidence that there is another symptom or sign coming from a different body system that is important to the reason why the patient presented in the first place. So what's the difference between a detailed examination, a detailed history and physical, and a limited? So as I just explained, the detailed one would be covering each individual body system or organ system, which is about 12 or 13 organ systems, and it is required for patients presenting in certain areas, for example, the hospital emergency department, and in other areas like the intensive care units, for a detailed examination, because this allows for the complete reimbursement that is tied to the diagnosis that the patient eventually is assigned to. However, if the examination is not complete and has not addressed the systems review of each individual body system, it leads to reduced reimbursement. There are some caveats to reduced reimbursement in medicine. Those caveats typically don't apply to physical therapy, so I'm not going to delve in details into that. Those caveats are usually situations in which a detailed examination is required but cannot be completed because of imminent danger to life. And that is beyond the scope of this discussion. However, limited examination looks at only the body system that appears to be most likely involved with the complaint for which the patient has presented. If a limited examination is done with no caveats, in that case, reimbursement is reduced. With all these details, the question begs asking is, do physical therapists need to perform a history and physical, or do they just review one? Well, the answer to that is not as easy as you supposedly have a yes or no expectation. Physical therapists can do and should do a history and physical based on the situation and the need. So you need to be aware of how to do one and what language to use and how to write it. A patient who is seen for the first time in a clinic for a specific purpose, like a sports physical, would need a full history and physical, and it would not be there anywhere else. However, in hospitals or in case you are seeing a patient in a nursing home based rehabilitation or acute rehabilitation, inpatient rehab, you will see a history and physical in the chart. Now, in that case, you review the history and physical from the medical chart. There is one caveat to this inpatient setting, whether it is a hospital inpatient or rehab inpatient. The history and physical may not have been done before you see the patient, or even if it has been done, it may not be entered into the chart. In that case, the option of you to not do an examination or not do a self-directed history and physical is poor because you have a doctoral degree. So you cannot just say, well, there's no history and physical in the chart. Undoubtedly, a lot of PTs do get away by saying there's no history and physical in the chart, so we'll hold until something is in the chart. That is a situation-specific decision. If there is no history and physical and a physical therapy evaluation is imminently important, then go ahead and go through the steps of the sections of the history and physical that you have learned or you will be learning. In regardless, you need to be able to perform a history and physical, and you need to be able to read through a history and physical to glean the most important points that can come out of that. In this slide, we review a basic organization of the history and physical. There are 5 clear-cut divisions of the history and physical. So obviously, one is the history component itself. Now, history has many subcomponents, and we will look into that. Then there is the component of physical examination. So we have history, we have physical examination. This is the component where you physically touch the patient to examine them. Number three is investigations. What are the investigations that have been done? And these investigations can be imaging investigations, or they might be other investigations such as lab work, laboratory studies. And then finally, you have the assessment. The assessment is taking the data obtained from history and physical and extrapolating them into whether there is a problem, what are the cause of those problems, can these problems be treated by physical therapy, or does it need external person to intervene? And then what would be the prognostic timeline for physical therapy to achieve a goal that is suggested within this um, time period that you are expecting? Based on this, you write the plan of care. This plan of care includes what you will do, what referrals you will make, what equipment you will suggest, and what discharge planning needs to be done. So those would be part of the plan of care. Now, it is important to now go into what are the segments of history that we are looking at. So, with history, we are looking at these components. A chief complaint. Why did the patient come to the therapist, to the doctor, to the hospital, wherever it is? What is the chief complaint? This chief complaint may be different for different people. For example, the patient may have come to the hospital because they were unable to urinate, difficulty in urination. That is the reason they're admitted. Decidedly, that is something you need to mention, but why were you consulted? And just saying reduced or decreased mobility is not a good answer because you don't know that. Maybe it is not even stated in the chart. In fact, many times they are not stated. So chief complaint is based on sometimes needing to ask the patient, do you have any mobility disorders? Can you get around okay? Things like that. So chief complaint is different for a different specialist. Now, how did the situation evolve? That is history of present illness, or HPI. As far as whatever is relevant to the chief complaint, that is what HPI suggests. Then we go into past histories. So there are several elements of past histories that we will review. There are special histories, and then there is a segment which is known as review of systems. So we will look at what those mean. And after we have gone, this entire section is the history section. There is no hands-on component here. You don't touch the patient unless you have a fair understanding of these histories. Next is physical examination. This is the hands-on component of the examination. In the physical examination, we have observation, where we look, so eye, and then we have systems review, where we touch the patient. A systems review involves several maneuvers, so we have tests and measures to go through to examine the patient. Next, there is investigations. So in investigations, we look at lab work, imaging, pulmonary function testing, and various other supportive examinations that were not done by you but is important for knowing to make an assessment. So in assessment, we look for a problem list, what is wrong, and then we look for rationale. Why is something wrong? Excuse me. And then finally, we are trying to answer, is this problem solvable? Is the reason this person having a set of complaints, is that fixable by your specialty? So that's assessment. Assessment is not a rehash of the examination that you have performed. If you have done an examination where muscle strength is less than 5, it is not rocket science to state patient is weak. What is important is to say there is weakness and why is it weak. That is assessment. That why determines the rationale for intervention. And finally, we look at the plan of care. So it is the intervention itself. What will you do? How will you educate the patient? What equipment will you address? And finally, what are the discharge needs of the patient? So, roughly speaking, this is an organization of a thorough history and physical. There are components within this, and if you need a checklist in your mind, have I done this? Have I done this? Let's look at the next slide. So this is an overview of the history and physical in a more detailed way. So let's look at this, and we will not delve on this. We'll go right into a more detailed discussion of each component of this overview in the next few slides. So there is a chief complaint, what brings the patient in? And based on that chief complaint, we'll look at the past histories. So the past histories, as I said, history of present illness, and those are the past histories. Once we have obtained the histories, we look into getting into physical examination. In physical examination, we need to first do an observation. How does this patient look? What are they presenting with is first impression, where you are looking at the patient and finding a general overview. So that is the general overview of the physical examination, the first thing that needs to be done. And then get a vitals right away, a vitals, and you know the breakdown of the vitals. So those are the first things within the physical examination. After that, we have systems review. And what are the systems that we need to look at? Well, as you know, there are 12 to 13 organ systems. There is a little bit of disagreement, or even you just say difference in opinion on whether they're 12 or 13, depending on how you classify the lymph system as a part of the circulatory system or not. But regardless, we do not need to do all 12 to 13 systems unless absolutely necessary because of something wrong with their presentation. But what we need to do definitely are the 4 systems that is part of the PT practice patterns in the guide to physical therapy practice. These 4 systems are cardiovascular, pulmonary, neurologic, musculoskeletal, and integumentary. These systems, these 4 systems, are the ones in the PT guide. Now, again, you don't necessarily need to do a detailed examination of each of these 4 systems. If it is very clear to you that it's a musculoskeletal problem, then you can go into musculoskeletal problem. But what if there is additional signs and symptoms of a different organ system? For example, the person who has got a back pain also has severe amount of coughing or a lot of phlegm in their chest based on how you hear them. In that case, an examination of the lung system, the pulmonary examination, may also be important. Then we look at the investigations that are done outside the patient room. For example, imaging and lab work and electrodiagnostics and pulmonary function testing. After that, we do the assessment and we do something called a differential diagnosis. What are the likely explanations for the given symptoms? And that leads us into the final diagnosis. A final diagnosis is coming to terms with the understanding that the most likely source of problem is somewhere within this system. And finally, we write a plan of care based on all of these things that you just reviewed. So that's a total overview of the history and physical. Now, when you are reviewing a history and physical, it is important for you to know that history and physical may not be current. A patient is in a dynamic state of change. That history and physical is true as of the time and date it was done. So it may be necessary to go and review a progress note which is closer to the date that you have seen. And sometimes, if there have been a lot of changes over a long period of hospital or inpatient stay, you may need to review more progress notes along the way to find out what changes might have happened during that course of stay. This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below. So now we will be looking at the chief complaint in more details. The chief complaint is why the patient presents to the clinician. Chief complaints may be uh, specific. For example, my leg hurts, or I had a knee replacement. Now, these kind of specific complaints are typical of outpatient practice. So, in the big scheme of things, if that's what you are planning to do, outpatient practice, it's very common to expect a very delineated specific area of a complaint. However, there may not be a chief complaint in specific frame of reference to what we do as physical therapists. For example, a chief complaint in a hospital would be difficulty in breathing, or severe nausea and vomiting, or chest pain, or um, headache, the worst headache of my life. On the face value of this kind of a chief complaint, it does not appear as if physical therapists would have a very important role or physical therapy intervention be appropriate at all. Yet there may be associated underlying problems that may require the expertise of a physical therapist. There are other situations where there may not be any chief complaints at all. For example, a scenario such as sports physical examination. In sports physicals, you are supposed to be examining a student athlete, for example, from head to toe to make sure they can do their sports activities without having problems. Or simply where people are just getting checked out, for example, return to work programs to see whether they can do a particular aspect of an assigned job. When I applied to Cabell Hospital for privileges in practice, they made me undergo a physical examination of lifting weights and walking with the weights a certain distance above my shoulder. And that was a situation where I had no complaint, but there was a physical therapist examining me. So, chief complaints are usually associated with a disorder for which the patient is having difficulty and they present and they state it, but it may not be a guaranteed scenario for every single patient. So, these are some examples of chief complaints. Chief complaints may be a very specific statement, like my shoulder hurts, or I have chest pain, like an elephant sitting on my chest and I cannot breathe. Uh, or somebody else may present the problem for you to consider, like my mom is falling and losing her balance every time she stands up, or that my dad is confused. He has been confused and he keeps wandering around. These are examples of chief complaints. However, sometimes, or not sometimes, but rather most of the times, we need to know how did this come around? How did this develop? And that part of the complaint, of how the main complaint started, is usually a component of history called the history of present illness, and that we will look at in the next section. So hold your questions about history of present illness until we get to the next section. In the next slide, we will look at what is called constitutional symptoms. So, constitutional symptoms are a specific type of symptoms. These are a generic, non-specific symptom that does not tell us which underlying process or organ system these symptoms are coming from. So, what are these constitutional symptoms? For that, I want you to look at an appendix in this presentation, which is Appendix 1, and it is hyperlinked from this particular slide. We'll give you a little bit more idea of what constitutional symptoms are. These constitutional symptoms happen all the time in every kind of setting, but do we know that they are constitutional symptoms and what makes them constitutional symptoms? So take a look at Appendix 1. Further on, in Appendix 3 below, I have given you a memory aid to remember constitutional symptoms. So after you have reviewed constitutional symptoms, look at Appendix 3, which gives you a recall mechanism for remembering what constitutional symptoms are. This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below. So now we will come to discuss history taking. What is history? So history has three broad components. Okay, history of present illness, past histories, and review of systems. All these three fall under history. A history of present illness deals with the circumstances only relevant to the chief complaint. So if my shoulder hurts, everything that you need to know about why my shoulder hurts, that's history of present illness. Okay, it's got nothing to do with the fact that 3 months ago I fell at the edge of the lake because I was trying to catch fish and my ankle twisted. It's got nothing to do with my shoulder. How long has my shoulder been hurting? If it started when I fell 3 months ago, yes, then it becomes relevant and it becomes part of history of present illness. But it's very unlikely that somebody is just sitting for 3 months coming to you after that with that complaint. So history of present illness only deals with the circumstances specifically associated with the current problem. Okay. Typically, that happens within the last 30 days or so. Not a rule, but that is very common. Now, past histories deal with all other medical histories that has happened in the past. And the review of systems is a very special part of history. So let's take a look. As I said, history of present illness relates to the story of the chief complaint, how did it develop, and anything that is extraneous to the story of how the chief complaint developed, that is not relevant. Okay, so patients in certain cases will not tell you what uh, the circumstances of the story developing were. They may tell you incomplete, or they may negate or not feel required to tell you some parts of the story that led to the present complaint because they filter it. Now, this filtering is an important concept. Okay, so the filtering that a patient applies to their own story is based on various factors, whether they're
whether they personally feel, based on their own medical knowledge, that they don't need to give you that information because it's not relevant, in their opinion. Or there might be an additional thing that they're embarrassed about something, okay, and they don't feel that that is necessary to uh, relate that to the doctor or the clinician, whatever the clinician is. So this type of filtering is very dangerous. They don't realize it, but you need to understand that that can happen, and that may actually be the uh, make or break for understanding why the patient's chief complaint is occurring. So to get the smallest detail may be the clue to finding the diagnosis of why the patient is having what's wrong. It is important to probe the patient. It is important to remember that excessive interruptions to their story is not good unless there is something that you feel that may be missing. Now, four problems may happen in getting a history of present illness. Number one problem is excessive interruptions. This may make the person forget details to their problem, okay, or they may simply get irritated by the clinician's approach. Number two is that the patient may not provide sufficient information because they filter, like I told you, okay. Now, patients may digress too much. Oh, my aunt Jenna said, James, dear, why don't you come to my house? So I swung my legs over the edge of the bed. You see, these words are completely useless for any purpose that might be important to clinical rationale. This uh, this is where you may need to interrupt, okay, or may prompt the patient to bring them back on the track from the point of digress, okay. And in some cases, patients may be confused. If they're confused, then you might want to prompt them. Otherwise, allow the patient to state their condition in their own words. A past medical history is a whole um, collection of every single past history that there might be. So this includes medical history, surgical history, medication and allergy history. In cases of women, obstetric and gynecologic history, and for men, you also want to throw in sexual history. So uh, OB and gynecologic history in women would automatically delve into sexual history, whereas in men, sexual history could be a separate history. And then social history. We'll look at all of these. What is important for you to remember is it's important to get medical and surgical and medication and social histories. But certain things like obstetrics and gynecologic history and sexual history is reserved for very specific scenarios. So if you're dealing with a situation where there is probably need for genetic counseling, probable need for understanding infected patient's sexual partner history, um, these are scenarios where you need to ask those questions. Otherwise, we do not always ask these questions. We steer clear of them. Now, in the past medical and surgical history, we only cover past histories not related to the history of present illness. Okay, so these are distinctly past diagnosed entities. If there is a correlation to the chief complaint, it switches over to the history of present illness. Medication history, we are trying to find out what medications the patient is on. There are two components to medication history. In the first one, we are trying to find out what medications the patient is currently on. And this is important if the patient is, say, in a hospital. Okay, therefore, we know what effects and side effects of these drugs can we expect as far as our relevancy to our needs. For example, a patient on a drug called furosemide, which is popularly called Lasix, will make a patient pee frequently. urination frequently, but also may end up with causing the patient to have very low potassium because Lasix makes potassium leave the body. This entire class of drugs that Lasix belongs to does the very same thing. Now, if potassium drops, the outcome of that can be pretty bad. Low potassium can lead to cardiac arrhythmia, lack of rhythm of the heartbeat, which can make a patient either just pass out, which we call syncope, or it could do far worse things like throwing a blood clot, which can cause a stroke or a pulmonary embolism. These scenarios become important when we know uh, in the back of our mind that, oh, this patient is on Lasix. Why is he so dizzy? Why is he looking not good? Let me take a pulse. And if we find the pulse is abnormal, we could think, oh, maybe there is potassium abnormality. So we need to notify the physician. Would you please check for potassium? So that's why we need to know what is the present medication. Uh, Sometimes um, it is in, these patients may not be taking all the drugs that they were taking at home. So it is important to know what drugs were they taking at home, because sometimes the doctors will stop the home medication and there may be a medication or more than one medication that is uh, important for some vital function, but the doctor did not know it because of various reasons. So there's no one reason. It's not necessarily the lack of knowledge, but that can be too, because let's say a cancer doctor is seeing a patient and is not aware of a neurologic problem that the patient was having at home, and they have stopped all the medications, and the patient gets symptoms of that neurological disorder, and the physical therapist is contacted, and when the physical therapist arrives, they find, if they did a proper medication history, they would find that there was something that was being given at home and is no longer being given. That is the importance of taking a medication history for now and whatever was at home. It does not really matter in outpatient patients because those patients typically are on whatever drugs that they have been prescribed. They're taking one set of medications. But it is most important to review both sets if they were a hospital-based patient. Allergy history tells us about any allergies that patient may be known to have. So to learn about allergy itself and how it is caused, go back and review immune physiology. Briefly speaking, these are immunoglobulin mediated immune reactions, specifically IgE. Medication allergy and substance allergies based on previous history, these are noted. Patients may be allergic to latex. Latex may be a component of gloves or other medical equipment. In these people, using a latex glove may cause life-threatening reactions. It is not any one person's responsibility to know all this. You may see somebody taking latex gloves into a patient's room, and you may be um, professionally liable for not stopping that person, because you will be asked in a court of law, did you observe this happening? Why did you not stop it? So having this knowledge is very important. Same thing applies for food allergies. Now, medication allergy typically is noted in the chart as NKDA, which means no known drug allergies. Similarly, no known food allergies, NKFA, is for food purposes. In social history, we look at three situations. We look at the living situation of the patient, home details, how many, if it's all on one floor, how many steps there are to come into the house, how many steps the second floor if needed, Um, and who are the caregivers? Was the patient independent before, or is there somebody who would live with the patient now? Things like that. We'll look at the habits history. Habits history is basically the use of substances. Now, these substances, out of all the different types of substances there might be, there are three major ones: tobacco, alcohol, and drugs. In tobacco use, we look at whether it is smoked or chewed. If it is smoked, we look at cigarettes per day or cigarettes over a lifetime. So cigarettes or sticks per day is an easy calculation. You just need the number or how many packs they are using per day. So if a pack has 20 cigarettes, then so be it. Those are 20 cigarettes per day. Now, if there are cigarettes that's been smoked over a lifetime, we go for pack year history. Pack year history is calculated. How is it calculated? It is calculated by how many packs per day times how many years of smoking. So one pack per day times 20 years of smoking is a 20 pack year history. Along with that, we get alcohol and drug history, and in drugs, we look for whether they are intravenous drugs or smoke drugs. Obviously, intravenous drugs have a higher preponderance of affecting every body system, whereas smoke drugs typically affect the respiratory system, the mouth, and things like that. But eventually, long-term use, it doesn't matter. It affects many systems together. And finally, we look at what we call the functional status prior to admission, or FPTA. Was the patient ambulatory? How many, um, how many or what durable medical equipment they have, and were they needing something to walk with? In many cases, they would be needing a wheelchair. So were they using a wheelchair? Could they drive their own wheelchair, or did somebody else need to drive it? And also need to look at whether these drivable wheelchairs were power. In some cases, they were having power wheelchairs. And if we are asking about these equipment, we would like to ask whether they are in serviceable shape, or are they broken or not usable. So those are some of the important things to know. Finally, the component of history called the review of systems. A review of systems is a verbal review of the symptoms and signs if the patient knows of any. So, what is a verbal review? Verbal review basically is a checklist of complaints. You ask a question and the patient says yes or no. So, you could frame your questions like, in the recent or distant past, have you had any symptoms of, and then you go system wise. So this is basically a systematic examination. For every system, you ask a question that is appropriate for the system. For example, in head, eyes, ears, nose, and throat symptoms, do you have any difficulty with vision? Do you see color all right? Uh, do you have any difficulty with hearing? Do you have any difficulty with smell? These are questions for the head, eyes, ears, nose, and throat system. And for the throat, we may ask, do you have any difficulty swallowing? Similarly, for musculoskeletal disorders, we ask very specific questions. So for each system, you should learn the questions that you should ask to review their symptoms history. Again, this is basically a yes or no question, and this type of questioning is not related to the examination. When we come down to examination, there's a whole different set of things to do, but they are not verbal questioning. Please make sure you understand that review of systems is verbal questioning of complaints, and examination, you don't ask any questions, you actually examine for things. Now, this review of systems is uh, is specific in times when you know that the complaint is related to a particular system. Then we may just say, do you have any other complaints anywhere else? And if the patient says no, then that's okay. Then you don't need a systematic examination of other systems. Sometimes you do. In fact, most times in a full history and physical, a review of systems is done. But sometimes the problem is so obvious that you don't need to look elsewhere. So it's situational. You should, in your initial patient examination, endeavor to do a full review of systems, and then you will do a shortened examination in real clinical practice once you get proficient with it. In the in this slide, I have just alerted you to a memory aid. In Appendix 3 below, there are elements of past medical history that needs to be reviewed in the form of a mnemonic. So I have given you a couple of different ways, I think, but just check down in Appendix 3 for memory aid and how to remember the components of past medical history. And when I say that in reference to the systems, sorry, the diseases and disorders that we typically ask for. Do you have any history of heart disease? Do you have any history of breathing troubles and things like that? That is listed down there.
This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below.
Now, in we get to the section of physical examination. Physical examination is hands-on examination of a patient. This is no longer question and answer. You're done. Shut up and start examining physically. So, hands-on examination has these two components to it. I mean, it's not necessarily clearly cut different separate components, but it is the hands-on component, and it is a systems approach. Systems approach meaning you go system by system looking uh, for a problem associated with the chief complaint. So, um, while it seems that it is very extensive, it may be or it may not be. Let's look in a little bit more depth into this. In a comprehensive physical examination, there are three components. First is general observation. In general observation, you basically look, and when you look, you describe their presentation as they appear to you. It's a one-sentence statement as to how you find your patient as you visually inspect them. This is not a local inspection. This particular thing is just a gross assessment of how you find them presenting, whether they are well built, whether they are thin, whether they look cachectic, whether they look malnourished. Those things are mentioned in general observation, including whether they appear to be in distress or not. The next thing is vital signs. So vital signs this is where you measure the vital signs, and you state it. Typical PT education teaches you to use vital signs in cardiopulmonary examination. In medical examination, vital signs is a separate component after general observation. Now that is a better approach because it gives you a different idea, because cardiopulmonary examination has other components to look into. And then finally, there is systems review. Now, this is not a review of systems. Now, in systems review, you actually examine the patient system by system. In vital signs, you look for blood pressure, respiratory rate, temperature, and oxygen saturation in peripheral blood. These are the classic vital signs. There would be statements of pain being a fifth vital sign and things like that. Typically, you should not necessarily have to evaluate pain if there is no problem with pain. This issue about measuring pain as a fifth vital sign is actually a nursing, some nurse at some point decided to include it and popularize it and things like that. It is not the best way to do it. Regardless, however your clinical instructor wants you to do, you may have to do. But these are your classic vital signs. Back to general observation. So how does the patient appear? They're tall or short, well-groomed, disheveled. What is their attitude? What's the weight? What's the position that you found them in? And distress. Those are outlined in this particular slide. So these are some examples of general observation as it is written. So try to, once you read it, try to extrapolate that and think about how you would find your patients. Okay. Now, the final part of the hands-on component of physical examination is the systems approach, which is called systems review. This is the system-by-system examination of the patient. Um, as I said before, it is not review of systems, and this is not where you ask any questions. You do the examination. Now, if you're still confused between review of systems and systems review, I'd like you to go into Appendix 2 in this presentation and see the differences between those two. Inform your mind. Now, the systems review can be either a comprehensive systems review or a local systems review. Now, in general terms, if you are doing a comprehensive systems review, you go for the individual 12 to 13 systems of the body as you've learned it, and then you perform examination requisite to each system. For each system, there are a few things that you look into. We'll show that to you soon. When you go into an individual system, you would pretty much follow the same four things that we will learn about for each system. Now, you may not need to do a full comprehensive systems review if it is a general patient on a general day. The reason is that a comprehensive systems review is usually done for critically ill patients, mostly in hospitals, and in that place it's better to do a systems approach. But in a general outpatient based scenario, or even any most other rehab settings, you can get away with a local examination of only one to two, maybe three systems, the ones that are ratified by the American Physical Therapy Association. And those systems, or even in that case, not all those systems may be necessary to be done. So focusing, let's say, on the musculoskeletal system, that might be enough for many of your examinations. Talking of comprehensive systems review means a thorough look at all of these systems. So when a patient presents in the hospital with critical illnesses that often are constitutional symptoms, nobody knows what is causing those symptoms, then a thorough examination is done that examines all of these systems. It is not common for physical therapists to have to do all the systems review. It is definitely important to review them uh, if it is already in the chart, but not often that a physical therapist will do a comprehensive review. As far as APTA is concerned, they want physical therapists to be able to do four systems really well. And these four systems are neurological system, the cardiorespiratory system, the musculoskeletal system, and the skin, the integumentary system. In a typical local examination of the systems review, it is probably going to be one or two of these systems that take uh, the majority of your attention. So if it's a neurologic patient, a very thorough neurologic examination. If it's a cardiac patient, thorough cardiac and respiratory examination. If it's a musculoskeletal patient, obviously a thorough musculoskeletal examination, and so on. Now, because the musculoskeletal system is the primary system for movement disorders, we are essentially movement specialists. It is important that whether you are examining for neurologic or cardiac or skin, you must also do a musculoskeletal examination, even a cursory one, not a detailed one, and that's okay. Now, whether we choose to do a comprehensive examination of all the systems, or we do a local examination of one or two of these systems, each systematic examination within each system undergoes a few clinical steps which require physical skills. These clinical steps, there are four of them, are discussed in the next section.
This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below.
So as I mentioned, we are now in the review of the skill components of each system. And when we examine each system, we need to think about four clinical steps. These clinical steps are going to be, uh, the broad headings are going to be inspection, palpation, percussion, and auscultation. Now, of these four things, they are not always applicable to every single system. So percussion and auscultation are reserved for areas which are having body cavities. Whenever there's a body cavity, we look into it, and these systems of examination, percussion and auscultation, are skills that you need for body cavity examination. So therefore, for every system concerned, we have at least two skills that we must practice. One is visual inspection. So visual inspection is an examination of the local area. This is not general observation, it is visual inspection of the local area. Whereas palpation is the local hands-on examination. This local palpation involves everything from touch to movement, examining for sensation, and so on. Now, all the special tests are part of palpation. So you apply these concepts to individual areas of examination on whatever system you're studying, whether you're studying musculoskeletal by the musculoskeletal professors, you're studying neuro by the neuro professors, and so on. So inspection and palpation are the two skill components applicable for every system, whereas percussion and auscultation are typically over body cavities, and therefore we are talking about the chest, the abdomen, as two areas that requires percussion and auscultation. So inspection is the first thing that you do, and you visually inspect the area for deformities, for redness, obvious injuries where there is arm that is twisted and things like that. That means there is an obvious injury there. Palpation is the biggest part. You will learn this more in musculoskeletal, but also in other areas, every system area that is taught to you. So I'll teach you I'll teach you cardiorespiratory examination later on. And I already talked about this.
This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below.
At the end of the physical examination, it is important to remember that uh, physical functioning has to be evaluated. That is your functional examination. It's part of physical examination. Everybody does it. The physician does it. Therapist does it. Everybody does it. So functional examination involves the core activities that is part of physical therapy. So these are your functional examinations that need to be evaluated. Bed mobility, transfers, gait, balance. Not rocket science, and each one of them have been kind of laid out on this slide. I'll leave it at that.
This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below.
After we are done evaluating the function of the patient, we are done with physical examination. At this point, we have very specific queries. These queries are not blind queries. They're specific queries. We'll get into that, what makes it specific. But at this point, we want to evaluate our queries against available information. Or if no information is available, then we want to request of extra information. These are what is called the investigative uh, review or investigations review. And if it's not available, we request for it. Let's take a look. There are four major areas of investigations to review if they are available. Number one is lab reports. Number two is imaging. Number three is electrodiagnostics. And number four are others. Now, let's get this clear. You don't need all of these. You may not need any of these. But anything that works with body systems, that is not strictly a very local problem. Let's say somebody had an ankle sprain or a knee pain or after knee surgery rehabilitation or shoulder pain. It's very unlikely to need a huge amount of lab reports, even though some lab reports may be useful in figuring out what's happening. Regardless, the types of investigative reports that need to be looked at after the physical examination is over. You don't need to be in the presence of the patient unless they want to know what was the result of that last test they did on me. Then you need to review and maybe talk to them. But regardless, these are your major areas. So let's look at lab reports. By the end of your examination, you will have a fair amount of idea what is the underlying problem. Let's say a person who has been bleeding from their stomach is losing blood, and therefore their hemoglobin is probably low. And their chief complaint is, I'm pooping red blood or black blood, red blood in my stool or black stool. As you remember, upper GI bleeding in the upper GI tract can cause black stools because the iron gets digest or the hemoglobin gets digested and the iron is released in the stool, staining it black. Or you could have lower GI bleed, making it red. Regardless, person is losing blood somewhere, and that would make us suspicious. If the patient is also complaining of weakness, we want to know where is the weakness. The physical examination might have shown us that there is no weakness, but the patient is complaining about weakness. What about it? Well, we would like to look specifically at the level of hemoglobin and the red blood cells. That is what specificity is. If you open up the lab report section of a paper chart or of electronic medical records, there is a whole panel of tests that are done. Do we need to look at the whole panel? A cursory look is not going to hurt, but you need to have a very specific idea. Okay, I think that this one would be abnormal. Let me see what it is. And by golly, when you find it, it tells you, it strengthens your belief. Why is the patient weak? Why is the patient complaining of weakness? So have a good idea of what you need to look into. Obviously, you need to know physiology, you need to know pathology to be specific. Now, you also would understand that because there is um, an underlying disorder that might affect the patient's function, just like I stated, that if hemoglobin is low, patients will complain of weakness. That's not unusual. That is actually quite common. The question you would pose yourself is, okay, if the patient is weak because there's low hemoglobin, is the muscle also truly weak? And if your examination suggests that it is not, then there is nothing you can do to change that feeling of weakness, because normal muscle strength may be there. You cannot strengthen it any further. But the patient feeling weak is because of low hemoglobin. So be familiar with what each one of these parameters that you find abnormal, what could it do to the patient. Imaging studies are numerous, but the standard imagings are noted here. You have to have a good idea of what these imaging studies will show you. X-rays will show you two-dimensional views. They will show you usually some soft tissue pathology, but not a lot. But it is standard to actually get uh, X-ray for bony pathology, as long as the bone is not enclosure. So enclosures within bone are not shown well on plain X-rays. Um, Computed tomography has been these discoveries have been coming in, usually done by physicists. Computed tomography, medical resonance imaging, these are different technologies to image the body. PET scans, PET stands for positron emission tomography. SPECT scans, they stand for single photon emission computed tomography. And radionuclide scans are basically bone scans that show you things like very, very early stress fractures or cancer in the bones. So there are various indications and various strengths and various reasons why these tests are done. And as you learn pathology, you will learn what tests would be most appropriate. Will you learn all of these in class? It's doubtful, because we would not have time to go over every aspect of this. But you will get a baseline understanding of X-rays and CT and MRI. And most likely, even though I'm not 100% sure, you will hear about radionuclide scans, and Dr. Dauber might bring it up. As always, if you want to discuss this beyond the class, I'm available. Now, another class of studies is known as electrodiagnostic tests. And again, these tests may be just reports that you're reviewing. But physical therapists do perform electrodiagnostic tests. These tests are done on various tissues. Um, and The ones that physical therapists do typically are limited um, to the muscle and the nerves. And those are your electromyography and nerve conduction velocity. Okay, so these tests tell you how the muscle is. Does it have an intact nerve supply? Does it have a pathology, an intrinsic pathology or a neural pathology? So is the muscle itself defective, or is the nerve supply to the muscle defective? The nerve conduction velocities tell us if the speed of conduction in the nerves, both coming and going, there are terms called antidromic and orthodromic. One brings the signal from the cervical spine down to the arm, or one that goes from stimulation of the arm, it will take it back to the spinal cord and relay it to the brain. These are nerve conduction velocities, and there are normative values available for these. So once the test is done, it is compared to the normative values, and boom, you know whether it is slowing down or it's normal or it's cannot be faster. So either slower or normal. Okay, uh, so that also indicates to you if the nerve is intact. Because if there is a delay or complete disruption, that means the nerve is gone. Okay, and then we have cardiac electrodiagnostics. If somebody, let's say, for example, is fainting, and you know there are many causes of fainting. There are causes which are related to the brain, and so that would be a neurogenic cause. There are causes that are related to blood pressure. That's a vascular cause. And then there are causes that is related to heart malfunctioning in its beating. Its rhythm and rate may be defective. That is evaluated by cardiac electrodiagnostics. Let's say you're examining a patient because they are falling and passing out. And you have tested them for everything, and that is normal. Then you come back and say, well, cardiology, if they are not on the case, they should be, because I cannot find anything wrong with the patient. So cardiac electrodiagnostics are those studies that tell you if there's possibility of a heart-related reason for some underlying problem. And I just give you one example. There could be others. An EEG is done for various things related to how the brain sends electrical signals. The brain has its own electrical signals that is evaluated on an electroencephalogram. These are the commonest electrodiagnostic tests that are done. They're done by different people, and out of that, the EMG, NCV are two things that can be done by properly trained physical therapists in their clinics, and that is a source of business for many physical therapists in states that allow electrodiagnostics to be done by PTs. So another area of specialty practice. Okay, so what other medical investigations do we have? These are probably way lesser in clinical practice versus the ones that we have just discussed. These are various. These are not related to one area or one type of study. So that's why I've lumped it together in other studies. So these include biopsies, genetic testing, something called manometry, gluten challenge test, the glucose tolerance test, the bronchial challenge test, done for various reasons. Again, I just wanted you to be aware of it, that these are available. We will probably mention them in areas such as when we study, let's say, diabetes, then glucose tolerance test is done, or asthma, then the bronchial challenge test is done, or inheritable diseases when the genetic testing is done, and so on. Of course, biopsies are done for pathology in the tissue. Is there cancer? Is there infection? And things like that. Those are biopsied material that goes to the lab, taken out from the skin or internal organs, sent to the lab for studies. Okay?
This is a summary zoom of this entire presentation. As you have seen before, each one of these icons will give you a jump to the specific section below.
Done. We are done with examination. We have done physical examination. We have done part of which is functional examination. Then we have looked into investigative examinations. Now we are done with examination. Now we have a huge bunch of data. Data is nothing but crap unless you can analyze it. So data, there is data everywhere. Okay, I have students doing projects. They bring back data, but I cannot submit the data for publication because that data needs to be analyzed, and then I have to write it. Similarly, all this examination generates data, but that needs to be analyzed. It needs to be analyzed for all it's worth and figured out what is the basis of the patient's complaint. What they came in with a problem. So this is my examination. What did I learn from the examination? Remember this at the outset. This data is not the analysis. The data, when you read it, you cannot repeat it in your analysis. Your analysis is something that comes out of the data. Read between the lines of the data. It is not a repetition of the same fact. For example, let's take the statement of muscle strength. If you know that muscle strength normal is 5, and the patient's examination shows you that it is 3 plus, it does not take a doctorally prepared candidate to have to say, oh, well, it is less than normal, so the person is weak. That is not assessment. That is not analysis. Your untrained family member, your brother, sister, anybody, as long as they have normal IQ, will be able to tell you that, oh, well, if it's less than normal, then they're weak. That is not assessment. That is not analysis. If that's what you're thinking, you are barking up the wrong tree. Get down that tree. Find the correct tree to bark up on. So assessment is data analysis that leads to a final diagnosis. So what did you learn from the data that was collected? We extrapolate that data, and the process of extrapolation is complex. It is not designed for you to learn that here in this presentation. But this complex process is known as differential diagnosis. Is this osteoarthritis? Is this pain from osteoarthritis? Is it from rheumatoid arthritis? Is this septic arthritis? When we are going through the possibilities of what's causing the pain or the dysfunction, that is called differential diagnosis. And it's a complex process. It requires fundamental knowledge of anatomy, physiology, pathology, and pattern recognition. What are the patterns for osteoarthritis? In a knee pain, for example, person unable to walk. What are the patterns? There are patterns. If you don't know it, you don't know how, you will not make the right decision. And that requires that knowledge. And there are other skills, observation skills, properly evaluate or getting the right information out from the patient. These skills come with time. You have to read, you have to practice, you have to read again, you have to go get mentors, you have to see many cases, and then you will start doing it. So you are beginning the journey. This is the first few steps. Now, what are the elements of an assessment? What things would you like to look at? So first of all, you need to define, is there a problem and what is it? Okay, it could be more than one. So okay, patient is unable to walk. Okay, that's a problem. That is not the end of your assessment or analysis though. The real analysis is, because the patient did say they are having difficulty walking, so the problem is there and you acknowledge it. But at this time, the actual assessment tells us what is or are the causes of the problem. Okay, so it could be, do you you do need to be very clear. The cause may be one or it may be many, more than one. The next question to ask is this problem fixable? Can you fix this problem? Can you as a physical therapist fix this problem or fix the symptoms of the problem? Now you could answer only two ways. You could say yes or no. If it is yes, then how? And that how becomes your plan of care. Okay, I'm going to do this, this, and this. That's your plan of care. Good. But what if it is no? Then you need help. You need somebody else. Now, you could have a third answer. You could have an answer called maybe. I did not put it down here, but you could have that. The reason I did not put that there is that for one thing I ran out of space. But the other reason is that that maybe answer is a yellow flag. You don't know it. That doesn't mean that other physical therapists may not know it. You could actually be working with a much more uh, knowledgeable therapist colleague who would know it. And let's say they don't know it. Then you need to refer out. That is where you decide, okay, it's out of our expertise. We will ask somebody else from a different area to provide us with an answer. You may want to look at that. You don't want to get rid of the patient. You just say, I want to send you to somebody and get an opinion back. Or sometimes it is very clear that you cannot help, and then you send the person wherever they need to go. That's the end of it. So those are the elements of an assessment. And that ends this presentation. And now you are in appendix, so just review the appendix based on what I have told you in prior comments during this presentation. Good luck.